en otros países como lo es Perú, Panamá, Costa Rica y República Dominicana. Somos una compañía centrada en el cliente y es por esto que siempre buscamos dar un muy buen acompañamiento técnico, entregar transferencia de conocimiento, entregar una alta calidad en productos, innovación, con una amplitud de portafolio y servicios que nos permitan enfrentar los retos microbiológicos de las instituciones de salud en todos los frentes. Somos una compañía que evoluciona y se transforma buscando que nuestras soluciones vayan en concordancia con el cuidado del medio ambiente y en la búsqueda de proteger el bien más apreciado, que es la vida. Buscamos proteger la integridad de los pacientes y del personal asistencial, y es por esto que la División Hospitalaria de West acompaña a las instituciones de salud en el diseño e implementación de protocolos cada vez más eficientes, garantizando la disminución de riesgos microbiológicos. Una vez más agradecemos su asistencia a este importante evento. Esperamos lo disfruten mucho.
Las grandes historias se escriben con letras de pasión, compromiso y visión. En West Química, estamos orgullosos de hacerte parte de un proceso de transformación que sigue su marcha. El mundo ha cambiado y nosotros con él, entendiendo a la vida como un propósito y a la bioseguridad como meta permanente y principal catalizador de nuestro progreso. El conocimiento, la tecnología y la innovación nos han permitido avanzar en refinados modelos de eficiencia que ponen a nuestro cliente en el centro de nuestras acciones, orientando la estrategia a consolidarnos como expertos aliados en los principales mercados: hospitalario, agrícola, alimentos, pecuario, industrial e institucional. West, hoy, trasciende fronteras. Construimos un grupo sólido de talento y equipos de la más alta calidad y estándares internacionales gracias a una moderna infraestructura de producción y un laboratorio de análisis microbiológico. Buscando las certificaciones y el desempeño necesarios para llevar su operación a un nivel superior. Somos West, expertos que hacen química para que la química suceda. Juntos trabajamos por la vida.
Bueno, muchísimas gracias a todos, muchísimas gracias a WES por el patrocinio de este simposio. Es para nosotros un gusto iniciar esta actividad denominada Buenas Prácticas en Limpieza y Desinfección. Para nosotros, como siempre, es un honor tener al doctor William Rutala. El doctor Rutala, les recuerdo un poco, es profesor de investigación de la División de Enfermedades Infecciosas de la Facultad de Medicina de la Universidad Carolina del Norte, en la cual ha trabajado consolidando más de 38 años de experiencia como director de la Unidad de Epidemiología Hospitalaria y el Programa de Seguridad y Salud Ocupacional de Atención Médica de esta universidad. El doctor Rutala además es asesor del CDC y miembro del panel de dispositivos de uso personal y hospitalario de la FDA, del panel científico, también asesor de las estrategias de investigación antimicrobiana para desinfectantes de la EPA y de la Comisión Federal de Comercio. Adicionalmente, el doctor Rutala es miembro del Consejo Editorial del Infection Control and Hospital Epidemiology. Dr. Rutala, it's a pleasure to have you here in our symposium. Bienvenido, Dr. Rutala. El escenario es suyo. Go ahead. Thank you so much.
Thank you very much, Christian. Can you see my slide?
Yes, we can.
Yes, we do. Remember to put full screen.
Yes.
Yeah, that's great. Perfect.
Is that good?
Yes.
Now,
Don't forget to go to display settings.
You do the other thing that you do in the past, yeah.
okay. Good afternoon. It certainly is a pleasure to be here with you to talk about best practices in disinfection of non-critical surfaces in the healthcare setting. And what we're going to do is we're going to talk about a bundle approach. The second thing we're going to do this afternoon
Excuse me, Dr. Rutala, you need to do the same thing that you did before in the display settings. Yeah.
Yeah.
So put bigger the presentation right there. Yeah. Yeah, that's perfect. Thank you so much.
Thank you. The second thing we're going to do is we're going to talk about skin antisepsis, and we're going to talk about Chg treatment and skin site preparation. So let's begin with the very first part, a few introductory comments. One is my disclosures. Professional Disposables International is the only company that I have any association with. As far as the slides are concerned, you can receive a copy or get a copy of my slides at the website disinfectionandsterilization.org. Disinfection and sterilization is one word, .org. Now, we're going to begin by talking about, of course, the issue of disinfection of non-critical surfaces, and then we're going to talk about skin. Now, I think you all realize that there are many sources of healthcare-associated pathogens. And of course, we know a very significant portion of healthcare-associated infections come from our endogenous microflora, the microorganisms in and on us. As you know, we have more microorganisms in and on us than cells who make us who we are. But then there are also exogenous sources to include the environment. So those are some of the issues we'll talk about. Now, we're going to begin by talking about how we're going to prevent all infectious disease transmission via the environment. That's our responsibility to the future. Now, I know many of you know this, but we'll go over it very quickly. Of course, we know that the environment contributes to HAIs. We know surfaces are contaminated. Microorganisms survive for days, weeks, and months. Of course, contact with those surfaces results in hand contamination. Of course, disinfection reduces contamination on surfaces and therefore reduces hand contamination. And by reducing hand contamination, it reduces healthcare-associated infections. We also know that admission to a room that was previously occupied by a patient with an epidemiologically important pathogen increases your risk of infection. So if you or I were admitted to a room that was previously occupied by a C. difficile patient, our increased risk would be 235%. We know that the reason for that is, of course, transmission of microbes from environmental surfaces on hands. So healthcare workers touch surfaces, and then of course they transfer those surfaces in providing patient care. We also know that of course hands touch surfaces, and of course the hands of patients touch surfaces, and the hands of patients will touch an overbed table or a bedside table. And if that's contaminated and they bring their hand to their eyes, nose, and mouth, you could get transmission of a healthcare pathogen. Now, as I mentioned, we're going to talk about a bundle approach to the disinfection of non-critical surfaces. So that's going to be our best practice. Now, I know most of you are familiar with a bundle, but essentially a bundle is a set of evidence-based practices. These evidence-based practices, when performed collectively and reliably, have been proven to improve patient outcomes. So there's going to be 5 parts to our bundle. So these are going to be all evidence-based practices that we're going to discuss that, when done appropriately, will reduce the risk of healthcare-associated infections via the environment. Now, we're going to go through each of these bundle components one by one, but you can see there's 5 parts. The first part involves procedures. The second part involves products. The third part involves education. The fourth is compliance. And the fifth is implementing no-touch room decontamination technology. Now, we're going to spend a couple minutes on background. And by background, what we're going to say is, of course, there are these epidemiologically important pathogens that have a role in transmission via the environment. We already mentioned that surfaces are going to be contaminated with these epidemiologically important pathogens. And this is just one slide involving one pathogen. The one pathogen is MRSA. And you can see from several studies that the average contamination rate for an item in that patient room is about 37%. And we also know that not only are these surfaces contaminated in these patient rooms, but they're contaminated, as we mentioned, for days, weeks, and months. And of course, the months pertains to C. difficile spores. Now, there's what is a very important finding approximately 10 years ago. And the finding was that hand contamination occurs as frequently by touching environmental surfaces as by touching the skin of patients. So this was a very important finding because it recognized that hand contamination occurred as frequently by touching the environment as by touching a patient's skin. And these are a summary of those results from that particular study. So that's why, of course, disinfection of surfaces is very important. There was an overview that was done, or review paper that was done just a few years ago by Dr. Creutzfeldt-Jacob, who actually tried to look at whether improved surface cleaning and disinfection reduced healthcare-associated infections. And when he reviewed the literature, he essentially showed that improvements in the effectiveness of cleaning and disinfection, whether they were education practices, audit and feedback practices, or addition of housekeeping staff or specialized cleaning staff and automated technologies, those improvements resulted in a reduction of healthcare-associated infections. So the bottom line is, if we make improvements in environmental disinfection, we can prevent transmission of pathogens and we can reduce healthcare-associated infections. And of course, the reason for saying that is that supports comprehensive disinfecting regimens. Now, I should hasten to mention that our goal is not sterilization of surfaces. Our goal was essentially to reduce the microbial load to a level that is not going to allow transmission of pathogens from the environment and non-critical surfaces. So let's begin by talking about the first component of the bundle. Remember, there's going to be 5 components. We need to do all of them reliably. The first component is develop policies and procedures. Now, we all know what policies and procedures are. What we need to do, however, is we need to standardize our cleaning and disinfection practices as it pertains to patient rooms and pieces of equipment throughout the hospital. And by essentially developing these policies and practices, we have to identify a frequency for disinfecting touchable hand contact surfaces. And what we're going to see is there's going to be data that demonstrates that that frequency should be daily, and of course, when spills occur and when the surfaces are visibly soiled. So we're going to talk about daily disinfection. We're also going to talk about disinfection when spills occur, and of course, when surfaces are visibly soiled. Now, what we're talking about here are non-critical medical devices and non-critical environmental surfaces. And by non-critical medical devices, we should have a policy that tells us how to disinfect them and when to disinfect them. And the when is daily, and of course, when soiled. We're also going to talk today about having a policy that discusses damp floor mopping with a disinfectant detergent. So the bottom line is we have to have policies and procedures that tells everyone in our hospital what we expect of them as it pertains to disinfection of non-critical patient care item and environmental surfaces. Now, we have mentioned that cleaning and disinfection is one step with a disinfectant detergent. That is, we don't do two steps. So cleaning and disinfection is one step. No pre-cleaning is necessary unless there are spills or gross contamination. So the only time pre-cleaning is necessary is when there's spills or gross contamination. Otherwise, it is a one-step process. Now, as far as non-critical patient care items, as I mentioned, we have to have some policy. The policy that is in the CDC guideline mentions the use of an effective disinfectant at the proper use solution and a contact time of at least 1 minute. Now, as I mentioned earlier, most vegetative bacteria, MRSA, VRE, and other microbes are essentially inactivated very quickly in about 30 seconds. So 1 minute, a minimum 1 minute. Now, obviously, if the manufacturer says 2 minutes and the government requires you to use 2 minutes, then you're going to have a wet time of 2 minutes. But minimally, the contact time is 1 minute. Now, of course, we have to ensure that the frequency of disinfecting these non-critical patient care items is done at some minimal frequency. And I'm going to propose that that minimum frequency is daily. And of course, we've already talked about the fact that they should be disinfected when visibly soiled. Now, not only do we have non-critical patient care items, we also have, of course, non-critical environmental surfaces. And we see a recommendation very similar for non-critical environmental surfaces. We have, of course, disinfected our non-critical environmental surfaces on a regular basis, and that regular basis is daily, when spills occur and when the surfaces are visibly soiled. Now, I have alluded to this fact of daily disinfection. It appears that, of course, not only is a disinfectant important, but also how often it's done is important. That is, we do want to use disinfectants because, of course, disinfectants kill microorganisms. And we want to do it at a frequency that has the advantages of reducing healthcare-associated infections. And I'm going to show you a little data regarding why daily disinfection is preferred. This particular slide demonstrates essentially the benefit of daily disinfection. Now, I'm sure you can see those dark black bars. Essentially, that is the frequency of hand contamination if you only disinfect the surfaces when the surfaces are visibly soiled. Now, hopefully you can see those hollow bars to the left of the black bars, and those hollow bars are essentially the frequency of hand contamination when daily disinfection is done. So you can see for both C. difficile and MRSA that daily disinfection provides less hand contamination, significantly less hand contamination than if you were to only disinfect surfaces when they are visibly soiled. Additionally, there is a paper that was published looking at the daily use of disinfectant applied to environmental surfaces. And they found that the daily use of a disinfectant was superior to using a cleaner because it significantly reduced the rates of healthcare-associated infections caused by organisms such as C. difficile, MRSA, and VRE. So we should use a disinfectant, and we should use it daily to optimally reduce contamination of the surfaces that could put patients at risk because of hand contamination of healthcare workers and hand contamination possibly of the patient. Now, there has been a lot of discussion regarding what surfaces we should disinfect. And I'm going to propose to you that we should disinfect all hand contact surfaces. I'm going to ask you to look at table 1. And table 1, you'll see essentially surfaces labeled as high, medium, and low. This is a study that essentially quantified touch frequency. And when we evaluated the microbial contamination level, we found no statistically significant difference in the microbial load between high touch surfaces and low touch surfaces. For that reason, the data to date suggests that we should concentrate on all hand contact surfaces rather than just concentrate on what we might think of as high touch surfaces. So this just reiterates that point, excuse me. All touchable or hand contact surfaces should be disinfected with a disinfectant because, of course, the surfaces are contaminated. High and low touch surfaces are contaminated similarly with microorganisms. Now, floors. Floors have been an area of discussion for many years. At UNC hospitals, we have always disinfected floors. But in the last few years, there has been some additional data on why we might want to certainly disinfect our floors. And the reason, of course, is floors are a potential source of transmission because they are often contacted by objects that are touched by hands. Now, there are a number of studies that were done by the Donsky group, and I'm just going to mention a few of the data points regarding those studies. And the first study that I'm going to mention is a study that essentially they put a non-pathogenic virus on the floor in patient rooms. So this non-pathogenic virus, it was a bacteriophage, was put on the floor. And then they watched where that non-pathogenic virus went after 1 day, 2 days, and 3 days. And that's what this slide shows us. It shows us essentially how quickly this non-pathogenic virus essentially contaminates surfaces in patient rooms that are in even adjacent rooms and nursing stations, and contaminates high touch surfaces greater than 3 feet above the floor. And these surfaces could be side tables or chairs and IV poles and so forth. So the point is that although you contaminate the floor with this non-pathogenic virus, it goes everywhere in 3 days. You can see it's in adjacent rooms in 3 days at a frequency of 100 to 80%. It's on personal items like cell phones, books, clothing, and wheelchairs. It's on high touch surfaces, and of course, it's in the nursing station. So the floor essentially resulted in contamination of personal items and adjacent rooms in a very quick fashion. So, of course, what they found is this non-pathogenic virus inoculated on floors, disseminated rapidly to the footwear in the hands of patients and to high-touch surfaces in the room. They found it on the high-touch surfaces in adjacent rooms in the nursing station. And of course, that suggests that the healthcare providers contributed to dissemination after acquiring the virus during contact with surfaces or patients. So that was the first of our bundle, policies and procedures. The second component of our bundle is selecting, cleaning, and disinfecting products. So again, we're going to select a product, a one-step product that cleans and disinfects. And again, no pre-cleaning is necessary unless there are spills or gross contamination. Now, as I alluded to, cleaning removes organisms and organic material. And of course, disinfection results in inactivation of those organisms that may be on the cleaning wipe. Now, as far as the effectiveness of wipes, you can see in this slide, if you look down to the highlighted area where it talks about a disposable wipe with a quat, the disposable wipe with a quat essentially reduces the microbial contamination on the surface by 4.5 logs. Now, the surface was contaminated intentionally with MRSA. And of course, if you can see also that if you were only using a detergent, not a detergent with a disinfectant, essentially the log reduction would be significantly less. So essentially it's killing, removing greater than 99.99% of the microbial contaminants with this disposable wipe with a quaternary ammonium compound. Now, today we and always will talk about how to conduct effective surface decontamination. Effective surface decontamination has two parts. It has good products and it has good practice. When you have good products and good practice, that's when you have effective surface decontamination or perfection. Now, as I mentioned, the second component in our bundle is the product. And we're going to talk about the product. Now, you know there are no ideal disinfectants, but of course there are many excellent disinfectants that we have available to us. When we evaluate disinfectants, we have to consider the properties of a disinfectant. And the properties of an ideal disinfectant would be things such as broad spectrum activity, fast acting, remains wet, not affected by environmental factors like organic matter, non-toxic or non-irritating to the user, surface compatible, meaning of course it's not going to corrode instruments or surfaces. It would be nice to have persistence, and of course it has to be easy to use. And we have mentioned that there are data that demonstrates that we should use these environmental disinfectants to prevent surface contamination and reduce the frequency of healthcare associated infections. Well, when we consider about healthcare associated infections, we also have to consider what pathogens cause most healthcare associated infections. And as you know, most healthcare associated infections are caused by vegetative bacteria. On the left part of the slide, you'll see essentially the most prevalent healthcare associated infections. And of course, they include bacteria such as E. coli, Staph aureus, Klebsiella, coagulase negative staph, Enterococcus, Pseudomonas, and so forth. All of these microbes are easy to kill. In fact, as you can see there, about 65% of healthcare associated infections are caused by 7 microorganisms. Now we know also there are some microorganisms that are harder to kill. And the harder to kill microorganisms would include something like C. difficile spores or norovirus, which is a non-envelope virus. Now, this particular slide, which you probably have seen, tells us essentially about the hierarchy of susceptibility of microorganisms to disinfectants. And what it tells us is that the envelope viruses are most susceptible. As we know, the SARS-CoV-2 is an envelope virus. Of course, the bacteria are very susceptible, and you can see by the arrow that's in pink that a low-level disinfectant will kill most of the microbes on this particular slide, to include even sometimes Mycobacterium tuberculosis or other mycobacteria. So some low-level disinfectants, they kill certainly the envelope viruses and the bacteria. They kill the fungi, and they kill some non-envelope viruses, and sometimes they kill mycobacteria. So essentially, they are killing the organisms that cause the majority of healthcare associated infections. Now, when I talk about low-level disinfectants, I'm talking about disinfectants that we're using on non-critical environmental surfaces and non-critical patient care items. And the list of those disinfectants would be shown on this slide. Of course, the more common ones are highlighted. Common ones include quaternary ammonium compounds, quats with alcohols, improved hydrogen peroxide, phenolics, and chlorine. And you can see the exposure time should be greater than or equal to 1 minute. Now, as I alluded to, sometimes we have to use a sporicidal product. And if we have to use a sporicidal product, of course, we have to identify what products are going to be effective against spores, such as Clostridium difficile spores. And in the United States, we have a list of products on the list K, which identifies these sporicidal products. And as you probably know, the majority of these sporicidal products are chlorine-based, although there are some other types of sporicidal products. So we've talked about policies, we've talked about products. Let's talk about educating the staff. And of course, we're talking about educating staff, such as environmental service staff and nursing staff, and really any staff that's associated with the application of disinfectants to either non-critical patient care items or to environmental surfaces. Let's say that, of course, we have to ensure that all the staff know what they need to do as far as cleaning and disinfection throughout the hospital. So we have to make sure that all the units that are cleaning and disinfectant understand how they are supposed to apply the disinfectants and essentially who does what. That is, some units, some surfaces would and medical devices would be cleaned by patient equipment. Some units, they may have some surfaces cleaned by nursing staff, but most of the non-critical items in a patient care environment would be disinfected by environmental surfaces. And of course, those environmental surfaces and other staff need to know precisely what's in the room and what in the room they are responsible for disinfecting. And every item in the room should essentially be identified as the responsibility of some staff member, and generally the staff member would be an environmental staff person. So this is a multidisciplinary group that essentially creates this standardized plan for cleaning patient rooms and pieces of equipment throughout the hospital, and everyone in the hospital has to know how, of course, this standardized plan is implemented as it pertains to cleaning and disinfection. Now, the next item we're going to talk about is monitoring compliance. Monitoring compliance. We're going to talk about essentially the need for monitoring compliance because you're going to see in a minute that we are not as thorough or complete in cleaning a surface as we need to be. So we're going to talk about monitoring compliance and how to essentially improve monitoring, improve completeness by monitoring compliance. So we're going to talk about practice. Now, these are some of the data which demonstrates that we have a lot of opportunity for improvement as it pertains to the thoroughness of environmental cleaning and disinfection. What these data demonstrate is whether you're looking at daily cleaning or terminal cleaning, is that overall, the environmental service member or the person responsible for cleaning is cleaning about 1/3 of the items in the patient room, either at terminal cleaning or daily cleaning. As you can see, the burgundy or the red bars are terminal cleaning, and even for terminal cleaning, only about 40% of the surfaces are clean. That means, of course, that 60% of the surfaces remain contaminated. If 60% of the surfaces remain contaminated, that puts the next patient in that room at risk for the previous patient's pathogen. And that's why we need to improve the thoroughness of cleaning from 30 to 40% to ideally 100%. So the issue is practice. We have excellent products, but sometimes we have suboptimal practices. That is, the surfaces are not just being thoroughly wiped, and all surfaces that need to be wiped are not being wiped with a detergent disinfectant that is used for disinfection of those surfaces. Now, how do we improve the thoroughness of cleaning? The thoroughness of cleaning is improved by one of a couple different ways. Certainly, we could use ATP bioluminescence, which measures organic debris, and essentially you're supposed to be below 250 and 500 relative light units. And then the other option is a fluorescent marker. At UNC hospitals and many hospitals throughout the country, fluorescent markers are used. A fluorescent marker is just essentially a transparent, easily cleaned, environmentally stable marking solution that fluoresces when exposed to an to a ultraviolet light. So the way this works is an infection preventionist or possibly a environmental service manager goes into the patient room and marks objects in the patient room, objects like overbed table or remote control. And of course, this is done unbeknown to the environmental service worker who has to go into that room. Now, after the room is marked, the environmental service worker cleans and disinfects that room. And then, of course, they leave that room. And then the person that has placed the marks on the surfaces in the room goes back and reassesses those markings. So essentially, if they mark 10 items and the fluorescence is present on all 10 items, then essentially that was very incomplete cleaning and disinfection because none of
Not sure what happened. Can you talk to us? Can
Yes.
you okay, great.
Let me continue and see if,
Yes.
let me know if we have problems.
No,
What I was mentioning is essentially you then go throughout the room and see if the mark is still there. If that fluorescent mark is still there, that means that the surface has not been wiped. So if all 10 marks are there on the 10 objects that have been marked, that means you have 0% thoroughness of cleaning.
Dr. Me? Hello, excuse me. Can you hear me, Dr. Rutala?
Yes,
I'm
I
an
can.
interpreter. Yes, I'm sorry. Something happened and I don't have the option of translating. So hold on a second if they can connect me again because they're not listening to yours. Oh, here we go. There we go.
Okay, we're back. Translation, yeah.
Okay, want to try again? Okay, so we're referring to essentially a marked surface. This is showing essentially a surface that has not been wiped. It's not been wiped because the fluorescent dot remains on the surface. So if you dotted 10 surfaces in the room and all the surfaces, the fluorescent dot has disappeared, that means that you have thoroughly cleaned that room because all the fluorescent dots that represent surfaces throughout the room have been removed by your wiping practice. The way that we essentially improve the thoroughness is we have the environmental service manager or the infection preventionist that marks objects. And as I mentioned, then the environmental service worker cleans that room. And then we try to get feedback of essentially identifying for the environmental service worker what surfaces have not been cleaned. And by feeding this information back through an educational process to the environmental service workers, you get improvement of the thoroughness of cleaning. And as you can see from the slide, the improvement goes from maybe 50% thoroughness of cleaning to maybe 80% thoroughness of cleaning. Now, I want to mention that you have to constantly change the dotted items to prevent targeting of objects. If you only dot the same 5 or 10 objects, the environmental service worker can target those objects and really only clean that object. That's not what we want. We want to improve the thoroughness of cleaning by essentially disinfecting all hand contact or touchable surfaces. Now, this is a study that demonstrated that the fluorescent marker is the most useful tool in determining how thoroughly a surface is wiped and mimics the microbiological data better than ATP. And this just demonstrates that there's really no statistically significant correlation between ATP and levels of microorganisms on surfaces. So for that reason, we have used the fluorescent marker and not ATP to improve the thoroughness of cleaning. Now, as I mentioned, we're going to essentially disinfect the touchable hand contact surfaces with a disinfectant. We've mentioned why. The reason is that high, medium, and low touch surfaces are contaminated with similar levels of microorganisms. So we're not going to only disinfect high touch surfaces, or what we might think are high touch surfaces. We're going to disinfect all hand touch surfaces. Now, I should mention that in the future, there may be another method or strategy to ensure thoroughness. And that is, in the future, we may have a disinfectant that has a dye in it that fades over time. So essentially, you can see where you have disinfected, and in 2 to 3 minutes, that dye disappears. So of course, a colorized disinfectant allows you to more thoroughly clean the surface. The color disappears, and of course, you've hopefully improved compliance or thoroughness of cleaning with that particular colorized disinfectant. That's not yet available, but it is being developed. The last part of our 5 parts of essentially our environmental service disinfection bundle is implementing a no-touch room decontamination technology. Now, I think many of you are familiar with these no-touch technologies. Of course, the reason that we're using these no-touch technologies is that data has shown that effective surface disinfection and thoroughness indicators are just not enough. They're not enough to achieve disinfection and high rates of cleaning and disinfection. So we have to supplement our surface disinfection by another technology, being no-touch room decontamination technologies. Again, this supplements, does not replace surface cleaning and disinfection. Now, there are many of these no-touch room decontamination technologies. The ones that have been evaluated most comprehensively have been UV and vaporized hydrogen peroxide. As you can see, there have been many microbiocidal studies and many healthcare infection reduction studies. The one study I'm going to briefly mention is the study that's a randomized clinical controlled trial. It compares essentially a quat with quat plus UV. When a quat only was used, essentially we found 60.8 epidemiologically important pathogens. But when a quat with UV is used, that number is reduced to 3.4, or a 94% reduction. That 94% reduction results in a reduction in the colonization and infection rate from 2.3% to 1.5%, or a 35% reduction. So these data demonstrates that a decrease in room contamination is associated with a decrease in patient colonization and infection. So this technology is used in many hospitals in the United States. This no-touch room decontamination technology. It's used in addition to, of course, surface disinfection by wipes, and it is primarily used after discharge of patients on contact precautions. At UNC hospitals and hospitals throughout the United States, approximately 20% of patients are on contact precautions, and we try to use this no-touch room decontamination technology after discharge of these patients on contact precautions. So what we've gone over in the last 45 minutes is essentially how to disinfect non-critical surfaces using a bundle. And of course, we've talked about the bundle And we've said that we have to implement every component of this bundle. Since every component is evidence-based, we have to implement every component of the bundle with high reliability. Now, the next phase is going to be where we talk about skin antisepsis. And there's going to be a couple parts to this, and then we'll have an opportunity for questions. We're going to talk about skin antisepsis as it pertains to preoperative skin antisepsis, and we're going to talk about surgical site antisepsis. And then we're also going to talk about CHG or chlorhexidine glutenate treatment or bathing. Many of you may know that in hospitals throughout the world, they are doing chlorhexidine glutenate bathing. It's sometimes preferred that we call it treatment. By calling it treatment, it's more likely to be accepted by the patient and more likely to be done by nursing. So we'll call it treatment, but this essentially is done very commonly in ICUs and step-down units, and we're going to see data in a minute that demonstrates it reduces healthcare-associated infections, especially bacteremia. So we're going to talk about these three things: preoperative skin preparation, surgical site preparation, and then chlorhexidine glutenate bathing, or preferably using the term treatment. So let's talk about essentially surgical site infections real quickly as an overview. I think you know that the majority of healthcare, the surgical site infections are caused by endogenous microorganisms or skin-dwelling microorganisms. Certainly, surgical site infections can sometimes be caused by exogenous microorganisms from, for example, surgical personnel, the OR environment, or possibly instruments. But the majority of surgical site infections are caused by skin-dwelling microorganisms. We know that surgical site infections are responsible for about 30% of all healthcare-associated infections. And we know, as we just said, that there are some common skin microorganisms that cause surgical site infections, to include Staph aureus and Coagulus negative Staph aureus, Coagulus negative staph. Now, that's why we're going to talk about skin antisepsis. We're going to try to reduce the level of endogenous microflora by doing a couple things prior to surgical incision. One of the practices is going to be applying CHG either by a wipe or a shower. And then the other practice, of course, is the preparation of the site prior to a surgical procedure. So let's begin with pre-operative showering or pre-operative wiping of the patient's skin using a CHG wipe. Now, why do we have to essentially try to remove microbial flora? Of course, it's obvious that our skin and other parts of our body have high levels of microorganisms. And as far as high levels of microorganisms on skin, you can see that for every centimeter square in your scalp, there's 6 logs of microorganisms, or 1 million microorganisms. On the hands, you find anywhere from 4 to 6.5 logs. So anywhere from 10,000 to 1 million microorganisms per centimeter square. Of course, abdomen, you find high levels, and the perineum, you find extraordinary high levels of microorganisms on the skin. So what we're trying to do here is we're trying to reduce that level of microorganisms. As you know, we're not going to sterilize skin. We can't sterilize skin, but we can reduce the microbial load on skin so that the reduced microbial load will not allow the endogenous microflora to cause a surgical site infection. And this, of course, summarizes what we've said. We've said that studies have shown that decreases in surgical site infections with an introduction of a pre-operative antiseptic protocol have been done, and those studies have been published. We know that essentially that if you apply a effective antimicrobial like CHG to the skin, you'll get certain levels of CHG on the skin that will reduce the likelihood of a surgical site infection. So let's look at some data. Now, on this particular slide, what we're talking about is a CHG shower. Now you can see green bars, yellow bars, and turquoise bars. The green bars are the level of CHG on the skin with just an evening application of the CHG, and this is by a showering technique. The yellow bars are by a morning application of CHG, and the turquoise bars are essentially both a evening and a morning application of CHG. Now, the point that I wanted to make is when you have two showers, that is the evening before and the morning, you have a higher level of CHG. A higher level of CHG will essentially be good in essentially reducing microbial contamination of the skin. You only need about 5 parts per million to kill Staph aureus. And as you can see, if you do 2 preoperative showers, the level on the skin would be greater than 100 parts per million. Now, the other way of doing preoperative CHG treatment is by using wipes. And hospitals have begun using wipes similar to the way they once used preoperative showers. Well, who will receive a CHG treatment that is a CHG wipe? These are some slides from UNC Hospitals and how they are implementing CHG treatment prior to surgical procedures. And as you can see, patients should receive a CHG treatment the night before and the day of surgery. Now, you can see they are excluding patients having surgery above the neck, so eye dental surgery, or having non-surgical procedures performed in the OR or other procedural areas. So they're excluding some patients. Now, inpatients who receive both treatments on units where they are housed, that again, if they're an inpatient and they did not have the night before treatment, they would have a day of treatment, and it should be given within 6 hours before the surgery. And patients arriving from home for surgery will receive a day of treatment in the preoperative area. So again, it's ideal to have 2 treatments, the night before and the day of. 2 treatments will increase the level of CHG on the skin and of course, hopefully reduce the incidence of surgical site infections attributable to the endogenous microflora of the skin. Now, how do we apply the wipes? Again, this is something that is done at UNC Hospitals, and you can see that they are using 6 wipes. They rub each area of the skin gently for 20 seconds. You can see the first wipe is the wipe of the neck, shoulder, and chest. And I'm not going to read the rest to you, but you can see essentially how all 6 wipes are applied to the patient's skin. You do not wipe off the CHG, but you allow the CHG to dry on the skin because, of course, that just increases the CHG that will remain on the skin. If you were to rinse it off, that would lower the CHG levels. So it's something that essentially remains on the skin. It's applied, it dries. It may still feel sticky for about 2 minutes, but that stickiness goes away. So that's essentially how we can prepare the skin prior to surgery. Now, obviously, there's also a surgical site preparation that is done prior to surgery. Now, there are recommendations in our literature regarding surgical site preparation. As you can see, the SHE organization, the Society of Healthcare Epidemiologists of America, and the CDC recommend for surgical site preparation that you use an alcohol-containing preparation. That would be, of course, a chlorhexidine glutamate and alcohol preparation, or something like an iodophor and alcohol preparation. The World Health Organization recommends that you have alcohol-containing antiseptic solution containing CHG. Now, the other thing that we said we were going to discuss is CHG treatment and bathing. Now, as you are probably familiar with, there is a strong rationale for efforts to reduce the burden of pathogens on skin. So there have been many persons over the last 10 or so years trying to investigate whether the use of CHG wipes or treatment will reduce the burden of pathogens on the skin and reduce the incidence of healthcare-associated infections, especially bacteremias. Now, this is one slide that discusses essentially the effect of CHG treatment. The effect of CHG treatment / bathing, it reduces skin contamination. That's on the left side of the slide where it says a reduction of 2.5 logs on the skin. It also reduces hand contamination, and it reduces environmental contamination. And in this particular study, it reduced the acquisition of vancomycin-resistant enterococcus. So in this study, which was the effect of daily chlorhexidine glutamate bathing on skin, they reduced skin contamination, they reduced hand contamination, they reduced environmental contamination, and they decreased VRE acquisition. In this study, again, CHG treatment / bathing, you can see 14 studies, and 12 of the 14, or 86% of the studies, the CHG treatment / bathing was associated with a reduction in colonization and infection. And generally that reduction is associated with bacteremia or possibly a decrease in acquiring Staph aureus or vancomycin-resistant enterococcus. In this study, which is a meta-analysis, the incidence rate of bloodstream infections was reduced by approximately 40%. So again, these CHG treatments, they reduce the level of microorganisms on the skin, they reduce hand contamination, skin contamination, environmental contamination, and of course they reduce, in some cases, healthcare-associated infections, especially bacteremia and infections involving VRE and MRSA. Now, with everything in infection prevention, it's extremely important that we implement these practices. And many hospitals that have implemented CHG treatment / bathing, they have found after a week or 2 or 3 or a month, the compliance of staff with performing CHG treatment goes down. So it's important to ensure, and in some cases measure, CHG on the skin as a means of monitoring the effectiveness. Obviously, for infection prevention practices to be effective, they have to be implemented. And one of the practices that we have to make sure that we implement is something like CHG done on a daily basis to have the effect on reducing skin contamination and risk of healthcare-associated infections. So the point of this is that there's a growing body of evidence that has accumulated suggesting CHG treatment and bathing may be beneficial strategy to prevent colonization and infection with healthcare pathogens, certainly with pathogens like MRSA and VRE. There is a reduction in skin carriage, which may reduce dissemination of pathogens through the environment in the hands of healthcare personnel. This practice is now becoming routine. It's especially common in intensive care units. And to optimize bathing in a real world situation, we need to develop strategies to monitor compliance. And there are some tools that allow you to determine whether CHG is present on the skin. Now, I have a few tips for success from UNC Hospitals when they implemented this. They implemented in ICUs and step-down areas, as well as oncology units to include adults and pediatric areas. They certainly educated the caregivers about the importance of daily CHG treatment in reducing infections. They asked that it be documented, that is chlorhexidine treatment be documented. And again, they use the term treatment, not bathing, as given or refused under the daily care or hygiene comments. And of course, one of the issues is how to dispose of the wipes, and they recommend the wipes be disposed of in a trash can and not down a toilet connected to a sanitary sewer because of backup. Some of the contraindications: don't use wipes if patient have a CHG allergy, if there's radiation treatment that day, or if there's cancer treatment. Avoid areas with rashes or moderate severe burns. Avoid the head and face. Avoid lotions from home because many lotions can deactivate the chlorhexidine glutamate. And avoid rinsing off. Remember, we said that we want a concentration of CHG on the skin that is going to be microbiocidal or bactericidal to common skin microflora. As far as the don'ts, don't put wipes in with soap and water baths. Don't put wipes in a microwave or a blanket warmer. Don't put the wipes in the toilet, as we mentioned, and don't use for Foley care, which is another precaution. So what we've talked about is essentially implementing a practice, best practices for disinfection of non-critical surfaces in a healthcare environment using a bundle approach. And the bundle involves policies, of course, products, education, compliance, and no-touch technology. And we also talked about skin antisepsis. Of course, we talked about pre-operative skin antisepsis by showering or wipes with CHG. And then we talked about how, of course, to perform a surgical site preparation, and then the daily bathing for patients in ICU, step-down units, and oncology units. So what we have said is that certainly MRSA, VRE, C. difficile, multiply drug-resistant Acinetobacter comprise a growing reservoir of epidemiologically important pathogens that have an environmental transmission. And of course, we have to implement evidence-based practices. We have to ensure the use of safe and effective low-level disinfectants, and we have to ensure the thoroughness of cleaning. And we certainly have some methods such as fluorescence to ensure the thoroughness of cleaning. And lastly, of course, we have to use these no-touch room decontamination technologies, which have been proven to reduce healthcare-associated infections. As far as skin antisepsis is concerned, we talked about preoperative shower or CHG wipes, ideally the night before and the morning. And we talked that current evidence favors the use of alcohol-containing solutions. Typically, those alcohol-containing solutions would be CHG with alcohol or povidone iodine with alcohol for surgical site preparation. And then lastly, we talked, of course, about CHG treatment and bathing. We mentioned that there's a growing body of evidence that has accumulated suggesting that the CHG treatments may be beneficial strategy to prevent colonization and infection with healthcare pathogens in a healthcare environment. So I thank you for your attention. Again, the slides are going to be available at the site disinfectionandsterilization.org, and maybe we have some time for some questions.
Well, thank you, Dr. Rutala. That was a wonderful talk. We have two moderators, Christian, and I will be pulling some questions too. But let's allow Christian to start with lots of questions. That was a very clear, amazing talk. Thank you very much. Okay, Chris, you're ready?
Sí, muchas gracias, doctora Villegas. Doctor Rutala, espléndida charla, muchísimas gracias. He recolectado aquí algunas preguntas, unas que previamente me habían enviado. Esta es una pregunta de una colega que ha trabajado con nosotros, Adriana Jiménez, y es una situación particular que vivimos en nuestro país.
Luis, espérate, le pregunto si él va a hacer la traducción. Are you listening the translation to Spanish, or do you want me to translate you the questions?
Let me go down to my little globe here and see if I can get.
Okay, if not, I will go ahead.
I didn't do it that time. Should I just hit Spanish?
Yes.
Okay, next time I'll do it. I apologize.
No, that's perfect. So let's see if it works, and then you let me know and do like this.
Okay. Entonces, respecto a la pregunta es, algunas personas en nuestro país recomiendan que algunos desinfectantes no deberíamos reconstituirlos con agua de la llave, con agua dura. La Organización Mundial de la Salud menciona que no hay problema. Algunas personas que no están a favor del agua dura dicen que algunos desinfectantes, como los clorados, se podrían inactivar, pero la Organización Mundial de la Salud menciona que no. ¿Qué piensa usted de eso, doctor?
Well, I apologize, Christian. I didn't get that translation.
Please.
So maybe I put in the English channel, I don't know. Maybe just right here?
Does he has to click the Spanish version? I think he has to click the English version because it would be the opposite from Spanish to English. So let's try again with the English version because that's a long question. Chris.
Sorry, it's now clicked English.
Okay, Chris.
Yes, I can hear you. Thank you.
Okay, I'm in the Spanish version. La voy a hacer en español para que... Entonces, la pregunta es, ¿qué opinión tiene usted sobre reconstituir desinfectantes con agua dura, agua de la llave? La OMS dice que sí se puede hacer, pero en nuestro país, en algunas normatividades, mencionan que no porque se inactivarían el desinfectante. ¿Usted qué opina? Sobre todo para clorados, reconstituirlos con agua dura, agua de la llave, normal.
Yes, thank you for the question. The question involves diluting essentially a disinfectant with hard water or tap water.
Exactly.
As you know, or may know, many of these disinfectants are tested with very, very hard water. That is a very high concentration of divalent cations, very hard water. So they have been shown to be effective in the presence of hard water. So in the United States, some parts of the United States have very hard water and other parts have soft water. We really don't specify a certain concentration of hard water or divalent cations. So the bottom line is, it doesn't, to the best of our knowledge, it doesn't matter. You can essentially compare the disinfectant with whatever tap water you have, preferably a good potable water, but the concentration of divalent cations has not been shown to be important.
That's great.
Perfecto. Muchísimas gracias, doctor. Es un punto importante, sobre todo porque en nuestro país a veces hay dificultades técnicas y la norma exige algo que realmente no va a tener tanto impacto en la eficacia y tendría que ver con la reconstitución de estos desinfectantes. También tenemos otra pregunta y es, en alguna norma en nuestro país exigen rotar los desinfectantes, cambiar cada 3, 4 o 6 meses en algunas áreas como bancos de sangre, centrales de mezclas, centrales de gases arteriales, desinfectantes. Sabemos que hay mucha evidencia que menciona que no es aconsejable rotar los desinfectantes, no tiene ningún impacto. En su experiencia, doctor, ¿usted qué opina de esta práctica de rotar desinfectantes en las clínicas?
Thank you for the question. It regards rotating disinfectants. I believe it's not important to rotate. We have never rotated disinfectants at UNC hospitals when I was there for approximately 40 years. I don't know of any hospitals in the United States that commonly rotate. Certainly, I'm familiar with that concept, but I have no scientific basis for doing a rotation of disinfectants.
Okay, thank you so much, doctor. Doc, nos pregunta una gran amiga, Estela Vanegas, que si tiene alguna recomendación con respecto a las frecuencias de limpieza y desinfección ahora en época de COVID para SARS-CoV-2. ¿Alguna recomendación especial, frecuencia de la limpieza y desinfección?
Another excellent question. I think most hospitals have not modified their frequency of cleaning and disinfection attributable to the COVID epidemic. I imagine probably somewhere in the United States have done that, but I believe most have not. We recently published a paper in Clinical Infectious Diseases looking at environmental surface contamination with SARS-CoV-2. And it was very impressive how effective surface disinfection was in eliminating contamination with the SARS-CoV-2 RNA. As I mentioned earlier, only a couple investigators have found viable virus, that is the SARS-CoV-2 on environmental surfaces, but many, many investigators have found the SARS-CoV-2 RNA. But the studies are remarkable in that after disinfection, the RNA, the SARS-CoV-2 RNA was not detectable. And of course, before disinfection, it was frequently detectable. So disinfection has really been found to be very effective with SARS-CoV-2. And again, the hospitals that I'm familiar with have not modified their disinfection practices. For example, gone from once a day to twice a day. I have not seen that happen.
Muchas gracias, doctor. Tenemos también otra pregunta. Actualmente hay disponibilidad en nuestro país de productos 2 en 1 para la limpieza y desinfección. En algunas situaciones hemos notado que probablemente cuando hay más carga orgánica, el 2 en 1 pueda quedarse corto. Esto significaría que tendríamos que volver a hacer limpieza y desinfección y no usar productos 2 en 1 cuando hay mucha carga orgánica. ¿Usted qué piensa de esa situación? ¿Cómo ha sido su experiencia usando 2 en 1 en todos los escenarios, independiente de si quizá algunas superficies tengan más carga orgánica que otras? ¿La recomendaría?
Yeah, certainly we would recommend cleaning before cleaning and disinfection if there were spills or very significant contamination levels. If you saw significant contaminations on an environmental surface, I would precede the cleaning and disinfection with a cleaning first. Typically, that is not the case in US hospitals. That is generally the 1 2-in-1 product, that is cleaning and disinfection with a wipe is all that is necessary. But in cases where there's significant organic contamination, regardless of what it is, it's preferable to remove it before essentially you do the cleaning and disinfection.
Okay, muchas gracias, doctor. Tenemos otra pregunta del público que tiene que ver con su experiencia con luz ultravioleta en unidades de cuidado intensivo. En nuestro país, por infraestructura, muchas de nuestras unidades de cuidado intensivo tienen cubículos que tienen paredes de cristal. Entonces, conocemos algunas de las indicaciones y contraindicaciones de colocar luz ultravioleta allí. ¿Cuál ha sido su experiencia del uso de luz ultravioleta en estos sitios, en estas áreas de unidad de cuidado intensivo, cuyas paredes son todas de cristal, que son cubículos de cristal? ¿Qué recomendación nos daría en esas situaciones?
Yeah, we have used UV throughout UNC hospitals, but it really has been in private patient rooms. It hasn't been, for example, in a open area or a glassed area. The glass should actually prevent UV light, but I would really like to do a real quick evaluation of that before I made a declarative statement. But our use of UV, which has been over several years, has primarily been in patient rooms. As you know, the reason that UV kills not only in direct line of sight, but indirect line of sight is, of course, it bounces off walls, which results in essentially a log reduction even when UV is used for inactivating organisms, for example, behind a patient's bed. So long as the bed is removed from the wall, essentially the microbes can be inactivated. Essentially, as a one log reduction difference between direct line of sight and indirect line of sight. So it remains effective in indirect line of sight, even in settings where you are using UV in a patient room. To really, I'll investigate further the glass wall issue, but I believe the glass does not allow penetration by UV, but we'll confirm that before I leave that with you.
And I complement with one question. So you think it will be very important to move quickly in the operating room? The UV light will be essential in the sense of using it as a terminal, or would you use it between patients? What would be your recommendation?
Yes, certainly I know that UV has been used in operating rooms, but we have no data which demonstrates UV use in operating rooms reduce the incidence of surgical site infections. We just published a paper in Open Forum on Infectious Diseases looking at patients that are on contact precautions that go into surgery, and demonstrated essentially the significant reduction of microbial contamination after cleaning and disinfection. And I'm not sure that use of UV in that setting is going to further reduce the contamination to a level that's going to be interpretable by reduction of SSIs. As you know, the level of contamination of surfaces is low. Of course, surfaces should not be involved in transmission of surgical site infections.
But it's a practical issue. What do you think, Chris? Would that, being in Colombia, would that be where to put it, in a practical issue or what?
Yo pensaría que es, digamos, como lo veíamos y el doctor Rutala lo mencionó en la conferencia anterior. Creo que la luz ultravioleta es un complemento perfecto para muchos de los esquemas de limpieza y desinfección que se utilizan en hospitales y clínicas. También creo que podríamos utilizarlo en algunas áreas donde quizá sea difícil la limpieza y desinfección, o en áreas donde quizá existan problemas de ventilación. La infraestructura de algunos de nuestros hospitales, en algunos de ellos es difícil poder airear los sitios, tener problemas para efectos de las corrientes de aire y el flujo de aire, y creo que allí para desinfecciones terminales puede ser una excelente opción. Obviamente, como lo mencionaba el doctor Rutala y como lo escuchamos en la conferencia anterior, teniendo en cuenta que los esquemas de limpieza y desinfección convencionales funcionan. Entonces, muchas de las cosas que hacíamos antes de la pandemia y que seguimos haciendo funcionan, y algunas nuevas tecnologías son muy buenas en algunos escenarios donde quizá necesitemos reforzar eso para algunas situaciones puntuales. Yo personalmente no cambiaría, no protocolizaría, me iría a las nuevas formas, a pasarme a todo a luz ultravioleta o a todo con vapores de ozono, de peróxido de hidrógeno. No creo conveniente hacer eso, porque también hay una curva de entrenamiento importante en las personas que hacen la limpieza y desinfección en las clínicas, y eso evidentemente impacta directamente sobre hacer una buena técnica para efectos de la limpieza y desinfección.
Do you agree, Bill?
Sí, tenemos otra pregunta por acá que tiene que ver con la evidencia de los baños de la clorhexidina y la cirugía. Doctor Rutala, ¿usted pensaría que nosotros deberíamos protocolizar independiente de si son cirugías de alto impacto o no? Porque la clorhexidina, los baños de clorhexidina empezaron a utilizarse mucho en cirugías de alto impacto, reemplazos articulares, cirugías cardiovasculares. ¿Consideraría usted que muy probablemente debamos protocolizar esta práctica para absolutamente todos los procedimientos quirúrgicos?
I do. I do think you should have a protocol. Obviously, that protocol should be developed in collaboration with your colleagues and orthopedics and neurosurgery and other surgical areas, and of course should be consistent with the evidence in the peer-reviewed literature.
Muchas gracias. Y otra pregunta respecto a esta. Algunas personas que hacen cirugía ambulatoria hacen los baños de clorhexidina en la casa. Algunas personas hablan de esos 5 o 6 minutos que uno debe dejar actuar la clorhexidina en el baño. ¿Usted qué piensa del tiempo? ¿Cuál sería el mínimo tiempo de cirugías programadas? El paciente no está en cama hospitalizado y quisiera hacerse el baño de clorhexidina. ¿Cuáles serían los minutos que uno debería dejársela en el cuerpo?
You know, I don't know that we have any excellent data for that. Certainly, I have said many times, if I was going to have surgery, I would certainly shower with CHG the night before and the morning of. Now I might use a CHG wipe. It would depend upon how high the level of CHG is, using one technique versus another. And I would use the technique that gave me the highest CHG concentration on my skin. But certainly I have seen and have spoken to a colleague who has done many of those CHG studies and shower studies. And he would say that he would apply the CHG to the skin and essentially not allow it to rinse off for at least 1 minute. So he would get out of the flow of water for at least 1 minute, allow it to remain on the skin for at least 1 minute before essentially it was rinsed off. And I believe that is something that is done by many persons, although I would want to see the scientific basis for that. And I think it's an excellent question, but I'm not sure that we have perfect science. But obviously, it's very, very important that you just don't apply it and rinse it off immediately. You have to apply it, leave it on for a period of time, and then rinse it off, because of course, as soon as you rinse, you're removing a very high concentration of the CHG. I believe the study that I showed you, and I have to look it up, but I believe where it said 100 parts per million or greater with a shower the night before and the morning of, I believe they had it on their skin, remove themselves from the water stream for a minute, and then essentially rinsed off. But I'd have to verify that.
That could be, let me ask, that would be a practical issue sometimes it's difficult to stay in the shower for more than 1 minute. You may freeze in Bogota, but I'm thinking, what if you shower 2 days before, for example? If you shower morning, night, I mean, just to make sure, because the recommendation is only the night before, but I believe that maybe it's better to do it 1 or 2 days before. Is that possible? What do you think about? And the other thing, how to add mupirocin. That's the other issue, that we send people to put in their nose 2 times a day.
I certainly understand and agree. You know, the whole key is you want a high concentration of CHG on your skin. As we talked about with these CHG wipes, I think it would be interesting to see the similar data for CHG wipes. The benefit of a CHG wipe is you're not really removing it. You're applying it to the skin and you're allowing it to essentially build up by 2 applications. I'd like to see data as far as CHG versus showering to see essentially which gives you the highest concentration on your skin. As far as, you know, 2 days, you know, morning, night, that would probably give you a higher concentration than 1 day. And as you remember, there's only 5 parts per million of CHG necessary to kill Staph aureus. But, you know, if I were having surgery, I'd want the highest concentration I could possibly achieve.
Okay.
Bueno, muchas gracias, doctor Rutala. Sí, yo creo que también es un tema del nivel de ansiedad de la persona. ¿Cuánto tiempo se demora y aguanta en el baño bañándose con la clorexidina? Por eso fue que la doctora Villegas hizo esa pregunta. Otra pregunta, doctor Rutala, el cloro orgánico en algunos equipos y dispositivos biomédicos está contraindicado, pero bajo el modelo de los clorados como tal. Muchas de las pruebas que se han hecho con equipos y dispositivos biomédicos se hicieron con hipoclorito. ¿Qué experiencia tiene usted de limpiar equipos y dispositivos biomédicos con cloro orgánico? A pesar de que la ficha técnica del dispositivo en algunos no avale el uso de clorados.
Yeah, certainly chlorine is an excellent antimicrobial. Obviously, the higher concentrations, you get sporicidal activity. So when you get into the 2,000-3,000 parts per million of chlorine, you start to get sporicidal activity. The problem, as you alluded to, is deleterious effects. As you increase the concentration, you increase the deleterious effects. And of course, you do not want to use a concentration that will nullify your warranty of many of these medical devices. So my concern would be nullifying your medical device warranty by using a chemical that could have deleterious effects and no longer allow the medical device to be effectively utilized.
Please, ¿puedo preguntar una cosa? So coming to chlorhexidine, of course, is better the clothes than the bathing, of course. And we're trying to avoid water in the ICUs because it's very common in Colombia that they still wash the patients with water, which splits everywhere. It's a huge problem. It runs under your genitals, etc. The contamination is tough. So we are trying to implement no water for patients, the cleaning with no water. So that's number one. I would love to hear you about that. And the second thing is, how often will you use the chlorhexidine, bathing in the ICU patients? Bathing or clothes?
Yeah, the CHG, what is done with the CHG wipes?
Yes. Sorry, yes, exactly, with the wipes. I said clothes, but it's wipes. That's the word, yes. So, you know, you have a prolonged time of effect with chlorhexidine. Some people are a little bit concerned or probably reactions in the skin reactions, etc. And sometimes it's money-wise, money. So do you think you should use it every day in certain patients? Should you use it every other day, the chlorhexidine wipes?
Well, our current policy is to use daily on patients in ICU, step downs, and oncology patients.
Okay,
Obviously, if there are any clinical reasons for modifying that, that would be a physician call. But to your point, the benefit of using wipes is you don't have to use water. In fact, water is not good because it dilutes the concentration of the chlorine, the chlorhexidine glutenate, which of course you want as high as possible to have the benefit of reducing the skin contamination, environmental contamination, hand contamination, and reducing the risk of healthcare associated infections, and actually reducing the incidence of bacteremias.
wonderful. Thank you.
Doctor, actualmente la evidencia de la clorhexidina para la antisepsia de la piel en algunos procedimientos donde hace algún tiempo se contraindicaba como procedimientos del área genital y neurocirugía o inclusive en recién nacidos que no tuviera bajo peso, cada vez ha ganado más evidencia en términos de eficacia y seguridad. Nosotros hemos tenido alguna experiencia, sobre todo en neurocirugía, con el uso de la clorhexidina. ¿Cómo les ha ido a ustedes en estos escenarios donde al principio se miraba con mucho recelo el utilizar a la clorhexidina para la antisepsia prequirúrgica? ¿Cuál ha sido su experiencia?
Yeah, Christian, I'm not sure if I can add too much to your question. I certainly understand that, of course, there are certain mucous membranes that they don't want chlorhexidine in, and it is advised that those mucous membranes not be treated with chlorhexidine glutenate. I'm not sure if there's any more recent data that demonstrates that that prohibition has been eliminated or minimized. So I am sorry, I can't add to your question.
Let me ask you something while Christian reads the other question. What do you think about the chlorhexidine also wipes for gram negatives, or even of the evidence was very strong for gram positives, and I also remember reading that even if you colonize with gram negatives coming from the GI tract, it still works to use those chlorhexidine wipes or even showers.
Chlorhexidine glutenate is active against gram-negative organisms. I know most of the data are against gram-positives, but it has activity against gram-negatives.
The other question that I see here is, what about the operating rooms? For how long do you have to keep the disinfectants until the next surgery? So what is the timing between one surgery and the other one regarding disinfection of the operating rooms?
As far as timing is concerned, as you know, the disinfection is done between patients in surgery. And of course, a more comprehensive cleaning and disinfection of the OR is done on evening hours at night. Our practices in the United States is the disinfection is done using a low-level disinfectant. Essentially, everything that has been visibly contaminated is disinfected. And then there's a 6-foot perimeter around the OR table that essentially is disinfected. But the disinfection purpose is to restore the OR to a hygienic area, but it is not OR-wide that the disinfection is done. It's more within a 6-foot area of the operative table that disinfection between OR cases is done. Does that answer your question?
I guess so. The feeling of many people is that they have to allow for a long time between one. And probably it's important to clarify what is a terminal disinfection of the OR and what is the disinfection between patients.
Okay, let me add one thing to that answer, Virginia. As far as time is concerned, the only benefit of time is, of course, dilution ventilation. There's no benefit of time as far as the activity of the disinfectant on killing the microbes on surfaces. That is accomplished within a minute. That is, you don't get more killing by a disinfectant beyond 1 minute, as I can show you some studies that have actually evaluated 1 minute versus, for example, 60 minutes. Everything all the killing is done in the first 60 seconds or 1 minute. The benefit of time, if there is a benefit, of course, is dilution ventilation. In the United States, most ORs have anywhere from 15 to 25 air changes per hour. And of course, when you have 1 air change per hour, that reduces the microbial load by 35%. 5 air changes per hour reduces the microbial load in air by 99+%. So you get this benefit of dilution ventilation with air changes in time, but no benefit as far as effectiveness of a disinfectant on a surface.
Okay.
Eso es muy importante hacer énfasis en esto porque en nuestro país en algunas prácticas se cortizan los quirófanos y se guardan los quirófanos exclusivamente para procedimientos y se dejan como cortizados por periodos de tiempo, 2, 3 días. Ocurre mucho para cirugías de reemplazos articulares, por ejemplo, y esta no es una buena práctica y adicionalmente afecta la eficiencia administrativa de la clínica como tal. Es importante tener eso muy presente. Doctor Rutala, una pregunta. La clorexidina...
Christian, can I interrupt you for a second?
Yes.
I just want to comment on that. The paper that we just published in Open Forum and Infectious Diseases actually addresses the question that you just were commenting on. That is, we were always concerned, as you intimate, that orthopedic surgeons never wanted to follow a patient on contact precautions. So the study that we did was to see if a patient on contact precautions with VRE or MRSA or drug-resistant gram-negative rod, after disinfection, if any of those microbes survived in that OR, again, after cleaning and disinfection. And what we found was that even though essentially the preceding patient on contact precautions contaminated the room with their microbe, whether it was MRSA or VRE, those microbes did not survive the cleaning and disinfection. So essentially it nullifies the desire by many orthopedic surgeons to not go in that room or to wait a certain period of time before going into that room.
De acuerdo, totalmente de acuerdo. Doctor, nos envían una pregunta, una pediatra infectóloga, la doctora Tailandia, pregunta clorexidina y baños en recién nacidos que tengan infecciones por bacterias resistentes o que estén colonizados por bacterias resistentes. ¿Qué opina usted?
Yeah, I would have to look up the data on birth weights and use of CHG. There are some prohibitions based on birth weight and use of CHG. I'm not sure how that has changed over the last couple years, but there were prohibitions based upon birth weight and use of CHG, and I would have to review those data to answer that question.
Yo quisiera agregar algo allí y es que efectivamente el bajo peso al nacer sigue siendo una contraindicación importante, pero la brecha en recién nacidos donde no hay bajo peso tiene evidencia a favor con el uso de la clorexidina, o sea que sí podrían estar empezando a considerarlo como una opción. Nosotros en la unidad de cuidado intensivo pediátrica y recién nacidos, lo utilizamos y no hemos tenido problemas. Hay un punto también importante en los recién nacidos y es aquellos recién nacidos que tengan lesiones en piel o que tengan problemas en la piel, porque allí sí evidentemente puede uno tener problemas, sobre todo porque está hablando de aplicar un antiséptico en una superficie corporal más extensa si hay alguna lesión de piel.
There's another question, Dr. Rutala, about chlorhexidine 4% versus chlorhexidine 2%. If there is any difference, that's number one. And the second one is for hand hygiene, iodine versus chlorhexidine.
I heard the first part of the question. I think, is there a difference between 2 and 4% CHG?
Yes.
Actually, there's some data that are in the literature demonstrating that there's no appreciable difference between 2 and 4%. So you can use a 2% just as you would use a 4% CHG. Some of those studies were done by Elaine Larson. What is the second part of that question?
The second was hand hygiene between chlorhexidine and iodine. I mean, iodoferos. I don't know how you say it in English. With the iodine products, we're trying to implement the chlorhexidine, but people still have problems making the difference between alcohol, when to use the alcohol, of course, for your hands, when to use the chlorhexidine, and even sometimes when to use the iodine products.
Yeah, in the United States, as you I know, alcohol-based hand rubs are used 70% or higher for all hand hygiene activities. Alcohol-based hand rubs are used predominantly for hand hygiene activities. At UNC Hospitals, we have as an alternative to alcohol-based hand rubs, that is when you're doing soap and water wash, we have CHG. We have had 2% and we have had 4%. We do not have in our hospital the option of a iodophor. That is just for economy of purchasing. We have used CHG as the antiseptic to use with soap and water wash. But again, soap and water wash is less common than the alcohol-based hand rubs, which are very, very commonly employed for hand hygiene.
Wonderful, wonderful. So we have one last question, Chris, because we have a little video to show. So if you have any other question for Dr. Rutala.
No, I think that there's okay. We can finish right here. Dr. Rutala, thank you so much for your wonderful talk and for sharing with us all your knowledge. It's a really pleasure to have you here in our Congress. Thank you so much. Y gracias a todos por estar aquí con nosotros. Los dejamos estos 5 minuticos con unos videos.
Sí, muchas gracias a todos.
Thank you very much.
Miren estos videos que son muy
Thank you very
importantes y
much.
parte del entrenamiento. Thank you, Bill. What do you say?
Thank you for your translation. Bye now.
Bye. Thank you. They're going to show some videos now, video clips.
Innovamos para evolucionar en desempeño. Con West, sus procesos de control son más ágiles, cómodos y eficientes. Hemos desarrollado un portafolio de productos 2 en 1 para la limpieza y desinfección. Además, integramos procesos de auditoría y verificación que permiten una vigilancia de las buenas prácticas en la prevención y control de infecciones de manera rápida y sistematizada. Innovamos para brindar superficies más seguras. Con West, usted logra procesos de avanzada en desinfección mediante la emisión de luz ultravioleta de alta intensidad, eliminando un amplio espectro de microorganismos en tiempo récord y llegando a lugares de difícil acceso para su desinfección total.
Bueno, para aquellos, Cris, que están conectados, los esperamos hoy en la tarde para una sesión muy interesante de diagnóstico y pues terapia de diagnóstico, Diagnostic Stewardship, con la doctora Ellen Barón y Robin Patel, y el moderador va a ser Germán Esparza. No se la pierdan, que va a estar excelente. Muchas gracias a todos.
Muchísimas gracias. Un abrazo, que estén bien. Chao.